Afternoon, everybody. Thanks for making it back on time. I think we're going to get some stragglers from lunch, but we're going to try to stay on time. And it's my pleasure to introduce our next speaker. He adds international flavor to our faculty. So Dr. Nick Colyvas is from Johannesburg. He did train here at UCSF, and he's been in private practice before coming to join us at UCSF. And he's the best person to give this talk because he's doing a lot of research on meniscal repairs. So fantastic knee surgeon and shoulder surgeon as well. But I'm going to let him explain about all the new exciting things he's been doing in cartilage preservation and meniscus repair. Thanks.
Thanks, Anthony. Are we all good with the mic here? All right. Let's get started. So no disclosures for this talk. And I think I want to, something we do with our patients all the time is set expectations. And if you travel on any aircraft these days and look at the aircraft magazine, you see these advertisements for fixing your knee arthritis, taking a bad knee to a less bad knee with just a magic injection. And I'm not going to impinge on my regenerative medicine colleagues because I think they do a fantastic job. But I think the reality really is that most of those patients who have advanced degenerative arthritis are getting a knee replacement. That's probably where we're going. And what I'm going to talk about today is more of the patients that we think we can help with a sports medicine solution. And those are patients that are generally going to be younger. They have good quality cartilage, they have good quality menisci, they have intact cruciates, intact collateral ligaments, but they have a defect in that cartilage. That cartilage has an injury, and it's not a diffuse generalized arthritic picture, but more of a sort of isolated defect, a pothole in the road, if you would use that analogy. And that, I think, is where we as sports medicine doctors are able to do considerable good here. And I do think a lot of what we're doing now may be actually ultimately taken over by regenerative medicine, but for the moment, this is where we are with the state of the art. So for these articular injuries, they're not always symptomatic. The ones that are, it's the typical pain and swelling and sometimes a feeling of catching or even locking in there. But it's a wide range of symptoms. And there are, as I've already mentioned, the predominant ways we treat these are conservative. That's activity modification and the bracing, up to and including all the injections, which I think is covered elsewhere in this conference very nicely. But some of these I think we can help with surgery. Some of those that fail conservative management end up seeing us for surgery. And there are multiple options. And those options really are dependent on multiple factors. So it's a sort of a wide range that we have to consider, and a lot of factors go into that consideration and that discussion. And so what I want to talk about today really is just to go over the types of surgery we do in a sort of uncomplicated fashion, talk about their outcomes and because we're sports medicine doctors, we always want to know what are these surgeries and how are they going to affect return to play for our patients? So this is sort of the broad outline list, the categories of what we do when we talk about articular surgery. And really they fall into 4 different categories. I guess that's PRRR if you want to think of it as an acronym. But palliative is the first one. That's just a simple debridement, very limited value here. Then we go to the reparative choice, which is trying to get the body's own systems to heal the cartilage defect, to fill in that pothole. Then we go to the restorative, where essentially we're putting something into that defect to try and fill it. And then not actually dealing in combination with that, restorative or reparative, and realigning the bones, so the forces that go across that joint and that defect are reduced. And so if we talk about sort of the simple, easiest thing to do, and a lot of times that's why we do it, but I think this is really something that we don't do a lot of anymore. This used to be more popular. The reality is that the results are all over the map. Yes, some people get better, some people don't. If there's really loose edges of cartilage or loose bodies floating around in there, this is a good reason. And essentially, it's just a cleanup. It's just taking that mechanical shaver and cleaning up the edges, removing any loose bits that may be catching. It's a very easy surgery to do. It's a very easy surgery to recover from. It doesn't burn any bridges if you're going to do something later, but that implies that you probably will do something later, because again, this is not an ideal solution, and at most we see just a short-lived improvement. So I think this is either gone or on its way out as a way of treating patients. So the next step really is something that's been around for a long time and is considered something that has helped a lot of patients for a long time. But I think with some more critical analysis, we're finding issues with it, and that's something called microfracture. So here you have your defect, and essentially what you're doing is you're cleaning up the edges so you have a good quality, in A there you've got a good quality cartilage shoulder around it. All that quality, the cartilage is good, and then you put holes in the bone using a little pick that actually allows bleeding and any kind of marrow elements to come out there and form a new type of cartilage. It's not hyaline cartilage. It's not the original thing that was there. It's something called fibrocartilage. And it's reasonably good, but it's not great. So that fibrocartilage is something that's now easy to get by doing this microfracture, but it's not the original stuff. It's not the good stuff. It's an adequate, in many cases, replacement, but it's not the original. And the results tend to show, and again, this is sort of the typical, there's a lot of studies around this. This has been around for a long time. Good to excellent results in about 2/3 of patients. But the older studies suggest maybe a little bit better, but I think we've sort of realized that that's come down now. There was a lot of sort of excitement about microfracture really working for getting patients back, 20 years ago, and but it was noted even as early as 1991 that there was really a functional decline in these patients later. So they do reasonably well for the first 2 years, and then they start to fall off. And so now really what we feel about microfracture, we still do it. It's generally smaller lesions. I don't think it works as well for big lesions. But microfracture, which you hear a lot about, is a reasonably good thing, but it does not give you durability. It does not give you a long-lasting result. So that pushes us into the next choice for our surgery, which is something restorative. In other words, we're not trying to grow new cartilage and not have the body grow new cartilage, but we're trying to actually put new cartilage in there. And the sort of primary method we do that is by something called an osteochondral transplant. And this is where you can see from this picture here, you take a plug of bone and cartilage from an area that is good, the cartilage is in good quality, and you just transfer it over into where there is a defect. And this has a lot of advantages. You're taking actual cartilage, you're taking actual bone. Bone heals to bone very well. Cartilage is not so great. And you essentially replace that pothole with a nice filled area. But there are some issues. It's technically very hard to get the same contour from taking one. These are complex three-dimensional structures. Your knee has a lot of different shape to it. So taking it from one area doesn't mean that it automatically fits in another area. And you can only take a certain amount before you run out of areas that you are not weight-bearing on or less weight-bearing on. So the size of the defect starts to become important in this case. And we can overcome that to some degree by using allograft, so taking it from a cadaver tissue, but then again, it's not your own tissue, so there's some problems with that. We can also take multiple little plugs and put them in there, something we call the mosaic plasty, which is a really nice combination of words to use and sort of fill that defect up like that, and actually results are reasonably good. And that can help us sort of fill the bigger defects. And we've got good results with that in the right patient, and you're probably not looking at patients who are going to go back to the highest level. The bigger defects definitely do better with something like this than with a microfracture, which is what oftentimes many of the studies we have compares the new treatments to, is back to microfracture again. So if you can't use your own tissue, you can't use the patient's own tissue, the autograft, you will use the allograft. Again, pretty good results for these. The issues, oftentimes complications, they have to go back for a clean-out scope or a manipulation under anesthesia because they get stiff. So, and again, if lower weight patients probably do better. But there are issues with difficulty of actually getting these and matching size, etc. And the complications can be devastating. If this doesn't work, the whole cartilage seems to break down, and you're looking at a knee replacement as an alternative. And in a young patient, that's problematic. Again, people talk about whether or not microfracture versus osteochondral allograft. It's more expensive up front to do the Oates procedure, but in more durable results. So probably from an economic point of view, this works out to be a relatively equal treatment. But the Oates procedure, the allograft or autograft, seems to have better durability. Cell-based treatments. So now we're going to go, instead of putting a plug in there, we take some cartilage and we grow it in a lab, and then we put it back in there into that defect, into that pothole, with the idea that that cultured cartilage is now regrowing something much closer to the original hyaline cartilage. And this is called MACI. At this point, it used to be called ACI simply, but now because it's a matrix associated, it's added into a sort of a matrix that's put back in there. This is the sort of state of the art for these cell-based surface treatments that we're using currently. And this is 2 surgeries, so again, it starts to get more complicated. Your first surgery, you have to get a biopsy, and oftentimes you'll accurately size the lesion at that point in time, and then you implant it after you grow those cells. You do need to have a normal underlying bone for that. So MACI is not for everybody, but its considerations really is that it can be helpful for the bigger lesions. There's reasons not to do it. Older patients, patients who are over BMI of 35, and there are some complications that we see with MACI, but it's generally considered a very viable treatment for many of these patients. And the durability seems to be good for these types of surgeries. The 5-year outcomes are pretty good. They never look 100% normal on MRI, but in terms of clinical improvement, they seem to do well. And again, we seem to compare everything back to microfracture. There is very good data to show that actually MACI, particularly for the bigger lesions, is really a much better choice. In terms of the last sort of treatment that we do for articular cartilage, where we don't actually even touch the articular cartilage, is limb alignment. We always want to look at the alignment in these knees. If we have a varus knee and the varus is significant, and we're looking at a medial femoral condyle defect, filling that defect and not correcting the varus is probably going to put that repair or that restoration procedure under a little bit too much stress, and it's going to be an issue. So for many of these cases, we're doing corrective osteotomies. And the patellofemoral joint sort of is a separate joint. We do quite a bit of cartilage work for patellofemoral joints, and a lot of that requires realignment in order to offload that cartilage and allow that, whatever procedure we're doing, to work well. That's called a Fulkerson osteotomy. You'll see that a lot for patella instability, but also specifically for articular cartilage defects in the patellofemoral joint. So if we sort of put it all together, small cartilage injuries, probably a microfracture is still what most people are doing. I think that number is getting smaller and smaller. We're going to an Oates procedure for smaller amounts of, for smaller numbers of defects. Large lesions, I think you really have to consider either a MACI or a osteochondral allograft. And the patellofemoral cartilage are probably more MACI than anything else, just given the nature of the shape of the patellofemoral joint and the loads on it. Some of the newer surgical recommendations: juvenile cartilage, something called de novo, its proprietary name. These have some promising aspects to them. I don't think the data is complete yet. Something to look at in the future. Nothing that is specific at this point in time in terms of recommendations. The other sort of considerations, there are quite a few on the market or undergoing approval now, FDA approval. I think the future's going to be interesting to see where all of these go. They'll probably be compared to microfracture, of course, but I want to move on now. So sort of when are we getting these patients back to sports in our practices? And the reality is that for the right patient with this type of surgery, with articular surgery, if we've chosen the right type of surgery for this patient, if we've chosen the right patient for the surgery, once they've failed all their conservative management, I think we're getting pretty good results. The data would suggest we're getting 2/3 to 3/4 of the patients back to their sports. Of course, that's a sort of overall global picture. The argument when we go to our conferences is, which procedure works best. I think the good news is that most of these procedures are working. It seems like if you want to look at specifics, that the autograft plugs or osteochondral autograft transfers seem to work the best. They seem to give us the fastest return to play and the highest return to play. But all of these factors are really complicated and mixed up by the size of the defect, the size of the patient, all these different factors that go into there. And those factors are really sort of broken down, I think, quite nicely if you look at the data by age, the level of participation, the duration of the symptoms before you end up getting the surgery, the size of the defect, the previous numbers of surgeries, where exactly the defect is located. And, we never want to forget the social determinants of health, because they always add or complicate to our decision making. So what about age? Well, I think intuitively, we all would understand and agree that, younger has better outcomes. When we talk about younger, though, it's interesting because, under 25 seems to be clear. And then when we're talking about who's that older patient, well, that seems to be somewhere between someone older than 25 or someone older than 40. That range is, we're not 100% sure what we're calling the older patient when it comes to cartilage surgery. But bottom line is, the younger you are, typically the better you're going to do. The level of sports participation, well, I think we all see, these stories about the pro athletes getting back 6 weeks after a meniscus repair, and our athletes, we're not letting them play 4 to 6 months afterwards. So, there's something to the, greater access to the rehab, maybe a more timely recognition of the injury and getting them into care. And, you can't underscore the motivation concept as well. More motivated usually means better. What about the preoperative duration of symptoms? Well, again, kind of intuitively, you would figure that if they have a shorter period of symptoms, if they haven't been having a problem in the knee as long, so usually that means in more of an acute situation, the more likely you're going to get better outcomes. Anytime you've got any degenerative joint disease, which goes back to the beginning of my talk, if you've got an arthritic knee, it's now becoming much harder to fill defects if all of the road is not just a pothole in the road, but if all of the road has problems with it, then you're not going to get as good results. And then the longer you've been not using that leg, the longer your muscles have had to atrophy, and the more of a problem you're going to have with rehab. So I think duration of symptoms makes sense. Previous surgeries, again, makes intuitive sense, because if you've had multiple surgeries in the past, it's because other things haven't worked, and you're ending up essentially revising and trying to make cartilage grow where it hasn't grown in the past. So the more surgeries you have, the less likely you can get patients back to playing. The defect size, this is pretty clear. This is why we have lots of different sort of recommendations as to the different types of surgeries. I think smaller is clearly better. It makes intuitive sense again. There's some studies that are not clear as to whether or not the size makes a difference, so it might be something to do with the procedure, but for the most part, we think smaller is better. And the locations, I mentioned this earlier, that the patellofemoral joint is its own sort of issue. It has a different morphology, it has a different set of forces across it, and we find that it's very, very clear that the femoral condyle lesions really do better than patellofemoral joint. And some people ask me, what about tibial side? Well, that's pretty much awful. The tibial side, if you've got changes on the tibia, it's probably too far gone for any real articular surgery. In terms of the types of surgery, it looks like the Oates and Macy procedures really get patients back better, and I think the other point to this is that that's probably a more durable result. If you look at the literature, those patients, the whatever that replacement cartilage is, seems to be better than what you get with microfracture. Sorry, the Oates is the plugs. Yeah, the osteochondral allograft or autograft. And then this sort of is just another analysis that seems to show that allograft transfer, autograft or allograft transfer, the plugs, seems to have the highest rate of return. And there's something around timing as well of this, of what exactly you get the patients back to. But it seems like the Macy, the surface-based treatment, just takes longer to get incorporated and get that cartilage to a level where it's playable. So I think I've sort of given a good overview. I didn't do too much of a deep dive into the data, but I just wanted to sort of go over the ins and outs of a sort of surgical decision-making. Again, this is not for everybody. There's a lot of patients that are probably going to do well with conservative management. There's a lot of patients with arthritis in the knee that are really too gone for anything and are going to end up getting a knee replacement. But we have this group of, usually younger athletic patients who we can treat with articular surgery and see good results. So I think that the options continue to evolve for these patients. It's really an exciting place. I think there's going to be a really interesting place where regenerative medicine and surgery combine to be even more effective for us. That's still that chapter has not been written yet, but I think that really there's a good news story to tell your patients, if they're the correct patient, that that we can get them back to play if the condition is right, if the surgery that's selected for them is correct, and if their rehab is appropriate. And with that, I'll end and happily take any questions.
I just had a question. This is your talk seems to be more about the hyaline cartilage as compared to the fibrocartilage, but with meniscus, can you answer a question about?
Sure.
Is that okay if I ask? So,
Oh, no, it's fine. I only smile because I could probably spend about 2 days answering your question about meniscus.
Just the challenge of a discoid, or what the challenges of a discoid meniscus are compared to your normal meniscus.
So right at the beginning of the talk, I mentioned how we're talking about sort of filling these defects in normal cartilage, but you have to have a good quality meniscus. You have to have good stability, in other words, ACL, PCL. You have to have good, overall cartilage health. And we talk specifically about the meniscus. I think it's a given that you have to have a good quality meniscus in place. And when I talk about meniscus repair versus meniscus resection, it's because, of course, the sort of mainstay of meniscus treatment for so long has been resection, which has led to articular surface problems. And unfortunately, a lot of those tend to be more diffuse articular cartilage change rather than sort of a defect. So many times we're not able to provide these types of surgeries for people who have meniscus deficiencies, which is why across the country, across the world, there's a renewed push for meniscus repair rather than meniscus resection. In cases where we have an articular defect that we want to address, and we know we have a meniscus deficiency there, I think we're being much more aggressive now about meniscus transplants and or osteotomies to offload that area to try and put that meniscus back in. But of course, that's that patient who is in that time frame where they haven't developed the arthritis from not having the meniscus, but have a lesion that we can correct, and then we will actually replace their meniscus. We will recommend replacing their meniscus to try and address that. But I think that you're spot on in sort of identifying that articular cartilage is really at risk without a good meniscus. Go ahead. Sorry. Is that the question? What is the meniscus replacement like?
Yeah.
So meniscus allograft transplant is a outpatient surgery, and the biggest problem with it is actually finding and matching the patient with the correct size meniscus. The surgery itself, I think, has gotten certainly less complicated, and the results are actually reasonably good. We used to use it only as a salvage procedure. In other words, if nothing else worked, people who had, usually younger patients who had post-meniscectomy syndrome, in other words, significant pain, they weren't ready for any kind of knee replacement. Injections, conservative management wasn't working. You'd put a meniscus transplant in them, and that would give them pain relief, but wouldn't necessarily return them to sports and things like that. With advances in matching the menisci and the surgical techniques and the rehab protocols, we are getting a good number of those patients back to sports, and hopefully that trend is going to continue. All right. Well, with that, I'll end the talk. Thanks, everybody. Take care.